Thank you so much, Ben, and it's great to be in Dallas, and it's great that the TMA and Ben and his center here is organizing this symposium, and I'm always very excited to explain with my heavy accent things about the spinal cord, so it's very good to keeping you awake anyway. What I'd like to talk in the next few minutes is about myelitis, and I'm going to explain this network. But I always emphasize in the team effort, so I'm going to show you the network that we use in our institution, and as you can see, there are many people involved in management, and this is not a physician network. This is a network that includes specialists in physical therapy, rehabilitation, urology, and other type of specialties. And again, the management of a patient at this century is team effort. So the physician is part of that team effort. The physical therapist is part of that team effort. The urologist is part of the team effort. The dietitian is part of that effort. So when you are coming to centers like here at UT Southwestern, the advantage is that you are going to be exposed to that network. But in the community, actually what you may need to do is just make sure that you have a very good team playing for you as well. So make sure that there is a good communication with your primary care doctor, with your physical therapist, with other people around you. And the most important one is the family network. I mean, family is critical for keeping moving forward with many things that happen in this disorder. So the spectrum of spinal cord disorder is expanding dramatically. In the past 10 years, we pay a lot of attention to problems associated with multiple sclerosis, neuromyelitis, optica, and what we were calling transverse myelitis. And the spectrum is quite diverse, and what I'd like to do in the next several minutes is to tell you that many of these disorders actually focus and produce damage of the spinal cord, and there are many similarities, and also there are many dissimilarities or many variations in the presentation of myelopathies. So I don't think that we are able to understand what is going on in patients with transverse myelitis or myelitis if we don't understand what is the spinal cord. And what I'm going to do in the next few minutes is just a brief introduction to what is the spinal cord. And you already know this already, but I'd like to review briefly with you. So the spinal cord, in my view, I always explain in my center there that the spinal cord is the I-95, is the connection between New York and Washington, D.C., and the most important is to have that highway always working correctly. And the highway of the spinal cord is very complex. It's a very small organ. It's a very small part of the central nervous system, but there are many pathways going up and down, and those pathways are very critical for the function of our human body. And that pathway, that spinal cord, is contained here in this bony structure that is the spinal column, that is a very good protective system for keeping this spinal cord structure in good shape. And unfortunately, in some circumstances, that is may become a problem because some of the structure of the spine, the column spine, may damage a spinal cord if there is any trauma, there is any injury, or there is any hernial or any discal herniation that push against the spinal cord. But the other element that I want to emphasize is the spinal cord is comprised by a network of peripheral nerves that coming in and coming out, and that basically facilitates the communication between the spinal cord and the rest of the body. But the other element that is critical and crucial is the blood supply. So as the brain, as any part of our organs like the heart, the blood supply is critical for the normal function of the spinal cord. So as you can see, for maintaining the normality of this structure that is called spinal cord, we need a lot of elements, anatomical elements like the vertebral spine, the blood vessels, and many other structures attached to the spinal cord. So this is a cross section if we basically like to make an anatomical analysis of this portion of the spinal cord, and we do a cross-section, what we are going to see, all of this is the bony compartment of the spinal cord. Here is where the disc is attached, and all of these are portions of the spinal cord and structures that are attached to the spinal cord. So this is the main core of the cord that is surrounded by this thick layer of covering that is called dura mater, or this is part of the meningeal covering of the central nervous system. And inside of the spinal cord, there are different cellular elements that are going to provide either elements for the motor system or are going to receive information from the sensory system in areas of the gray matter. And as compared with the brain, the spinal cord white matter is outside of the structure of the spinal cord, and the gray matter is inside of that compartment. So what I like to make emphasis on this anatomical description is the symptoms that patients with myelopathies may experience are associated directly to areas that are affected by different pathologies. In other words, if there is a discal herniation, the likelihood that areas of the nerves that are going out or coming in are going to affect it. If there is a herniated disc, it's very likely, if the herniated disc is really large, that areas of the anterior portion of the spinal cord are going to be affected, and subsequently motor function may be damaged. If there are problems associated with vascular supply, obviously it depends what area of the spinal cord is going to be affected by those vascular problems. So there is a lot of heterogeneity in the pathological events that may happen in the spinal cord, and that depends, again, from the distribution of the lesions and the anatomical problems, to the point that if we have a lesion inside of the spinal cord, obviously the magnitude of symptoms and clinical effects are going to be directly related with the areas of the spinal cord function that are going to be affected. So in the case of myelitis or myelopathies that affect the structure of the cord, so the damage is going to be directly in the structure of the spinal cord. But there are other types of pathologies like herniated discs, for example. I mentioned that before. Herniated discs are not affecting directly the structure of the spinal cord because there is a damage inside of the spinal cord, but rather there is an extrinsic change that is going to produce dysfunction of the structure associated with the spinal cord. So there are different flavors of pathology that are going to produce symptoms. So Google Maps is now going to guide us to the different abnormalities that happen in the spinal cord. So if you have the spinal cord and you have the different segments of the spinal cord and peripheral nerves, we are going to have a different type of abnormalities. So there is a constellation of symptoms. Motor dysfunction, going to give weakness. There are problems associated with sensation that are going to produce numbness, pain. There are autonomic dysfunction that basically is the damage of nerve supplies to different elements of our bladder function or bowel movement functions and blood pressure. And all of those symptoms are going to be basically producing the constellation of problems that patients with myelopathies and myelitis may experience. So let me dissect the most frequent problems that patients with myelopathies and myelitis may experience. And what I like that you get from this information is an understanding why there is too much variability in the presentation of patients with myelitis and myelopathies. Let's start with the most common one, is the motor system. The motor system is a very well-organized pathway in which areas of the brain are going to control movement, and those cells, cells that are in the cerebral cortex of the brain, are going to generate orders to different muscle groups. And this order is going to travel from the brain into the brainstem and later into the spinal cord, and are going to produce specific movements in different areas of our body. So the process of movement and the process of motor function actually is extremely complex. And this is when I say there is a highway between the brain, and that highway is going to be localized in a specific tract that is going down to the spinal cord to have that motor control. So at any level of our brain or areas of the spinal cord, that motor function may be disrupted. If a patient has a stroke in the brain, that area of motor control is going to be affected. If a patient has myelitis, is because that area of motor control may be affected specifically at the level of the spinal cord. So again, when patients experience weakness, the neurologists, clinicians, physical therapists need to understand at what level the motor pathway was affected. It was affected in the brain, it was affected in the spinal cord, or was affected in the peripheral nerve. And that is extremely important because that will outline what is the best strategy for treatment and particularly for rehabilitation and physical therapy. So one of the complex situations that we have in analysis of patients with myelopathies and neurological problems is at what level the lesion is located. So in other words, our brain is beautifully organized, and we have a very sophisticated organization of different functions. And that is the situation in the spinal cord. So every element of the spinal cord, and this is a cross-section of the spinal cord. Outside is the white matter, inside is the gray matter. So the representation of different elements of function, our arm and our leg, is specifically distributed in that area of the spinal cord. That is one of the reasons when we are analyzing the clinical situation of our patients, we go and study what is the strength in upper extremity, lower extremity, and because that clinical analysis are going to help us to understand at what level this spinal cord is affected. Let me give you an example. Dr. Greenberg mentioned clearly that in the past we have used the term transverse myelitis. And the term transverse myelitis is somewhat misleading because transverse implies that all segments of the spinal cord or all areas of the spinal cord are going to be completely disrupted in function. Well, that doesn't happen all the time. That happens when there is a stroke of the spinal cord and the spinal cord is completely damaged, or when there is a trauma of the spinal cord because a motor vehicle accident or something like that, that the spinal cord gets completely disrupted. But in our practical view, that doesn't happen all the time. Many of you that were diagnosed with myelitis actually may have only focal areas of the spinal cord that are damaged, and other areas of the spinal cord are completely normal. And that is good, because if some area of the spinal cord is damaged, it's very likely the potential for rehabilitation and recovery is higher. If the myelitis inflammation destroys all the structure of the spinal cord, that is when we get in trouble, because the potential for recovery is going to be diminished. But in many patients with myelopathies, NMO, MS, or myelitis or stroke of the spinal cord, that damage is not necessarily diffuse. That damage may be restricted to focal areas of the spinal cord. Now, the other element that is extremely important is that the motor function is in different compartments. There is motor function that is coming down from the brain and is basically localized in areas of the white matter of the spinal cord, and there is other type of motor function that is in the gray matter of the spinal cord. So when patients have demyelinating diseases like multiple sclerosis or even some attacks of NMO, frequently the damage is in the white matter. When patients have strokes of the spinal cord or even neuromyelitis optica, that damage may be also in the gray matter. And when the problem is in the gray matter is when the magnitude of motor dysfunction is more extensive. Now, if we take a look, our motor system is similar to our highways. It's very well connected. So there are detours and there are different avenues to go in different places. But one of the things that are very important for the function of the motor system is our motor system is interconnected with the sensory system. So to the point that when I am moving my arm, my sensory system is detecting where my arm is located. So the function of the spinal cord is facilitating the integration of all of those physiological events. So this is a diagram basically that illustrates that when we are moving different elements of our lower extremities, the sensory system is simultaneously detecting the position of our legs. So that is one of the principles that is critical is when we need to move our body, our sensory system needs to know where our body is. That's the reason many of our patients with myelopathies that have mostly sensory problems have difficulties walking around because they may be strong. The motor function may be normal, but the sensory system is dysfunctional to the point that the normal function of that motor compartment is going to produce the symptom of gait disturbance, for example. So the sensory system is equally complex. The sensory system, again, is based in a network that instead of coming down from the brain, is going from the periphery up to the brain. And again, is to facilitate that the information from the environment and the information from all of the sensory receptors are received here in the regions of the spinal cord in charge of that function and are immediately transmitted up to the cerebral cortex where our brain is going to process the information and will give the opportunity to the central nervous system to coordinate motor function, sensory function, and other activities in that system. So when we are touching one thing that is very hot, our sensory system is immediately communicating to the brain, and the motor system is reacting, right? That happens in milliseconds. So this communication between the finger that is being burned and the spinal cord and the brain, and then the reaction of the muscle happen in a matter of seconds, milliseconds. So that is the beauty of the central nervous system. And that is, unfortunately, the problem that happens in some patients in which the spinal cord is damaged, that communication, that network is disrupted, right? And again, it depends at what level of the spinal cord is disrupted. So one arm may be affected, but the lower extremities may be completely normal. So that's the reason we are emphasizing in the past few months that probably using the term transverse doesn't mean too much. It's just a myelopathy, it's just a myelitis, it's something that's affecting the spinal cord. Now, the sensory system is not only the only system that is critical for the function. There is another type of system that we call autonomic system. That is a system in which is there is a very good control of other organs like bladder. And when patients experience problems in the spinal cord, bladder is frequently affected. Why? Because our I-95 here between New York and Washington is disrupted, and the communication is slow or is disrupted, and many areas of the body are affected. One of those organs that are frequently affected, like bladder, is going to be dysfunctional, and that's the reason one of the common symptoms that patients with myelitis experience is bladder dysfunction. And again, the problem is because that bladder is a muscle structure that depends on the innervation that is provided by different elements of the central nervous system and spinal cord, and is going to provide the ability to contract and relax, contract and relax. And if that myelitis or myelopathy is damaging the spinal cord, obviously that communication is going to be disrupted and is going to be dysfunctional. So in the future, one of the challenges for rehabilitation of patients with myelopathies is to make sure that we keep a normal function of these nuclei that are localized in the lower portion of the spinal cord and will facilitate the normal function of the bladder. There are new technologies like electrical stimulation of the spinal cord that are helping patients to have a much better control of bladder. And again, that is a very interesting development in the rehabilitation of patients. So we have now technology that facilitates that this network of stimulation remains functional, and urologists with a specialty in neurourology are using these stimulator devices to facilitate the recovery of bladder function. So I mentioned before, and this is just to summarize my previous slides, is in the spinal cord we have many areas of specific function. Again, I don't like that you memorize this, but this slide is just for you to have an understanding about the distribution of different functions. And this is the posterior area of the spinal cord. This is the anterior area of the spinal cord. This is lateral. And the distribution of function associated with the sensation are frequently in the posterior and lateral columns. The functions associated with motor control are frequently in the lateral portion of the white matter, as well as the anterior portion of the gray matter. So in summary, so we have different pathways going up, going down. Most of the pathways that are going up are associated with sensory function. Most of the pathways that are going down are associated with autonomic control and motor function. So again, when you are thinking about your spinal cord, think about a highway where there are many lines for different networks of neurological function. Now, we are going to move to the different phases of what happened in the spinal cord. And again, we are moving from the term transverse myelitis to other type of terms, particularly for characterizing better the role of the causes and etiologies of spinal cord damage. And there are diverse. So there are problems of immunity or of an autoimmunity that may produce damage of the spinal cord. Multiple sclerosis is one of those. Neuromyelitis optica is another one that is in the category of autoimmune and immunological problems that affect the spinal cord. There are rare immunological problems that may affect the spinal cord that are not necessarily in the category of NMOSD. For example, cancer occasionally may have the potential to produce immunological reactions that may damage the spinal cord. That type of disorder is called paraneoplastic disorders. And again, it's a catch-22. The immune system is reacting against cancer, and occasionally there is crossfire and misfiring against the spinal cord, and some patients may suffer from that. Trauma is a major cause of spinal cord dysfunction. Discal herniations occasionally may produce damage of the spinal cord. Compression of the spinal cord due to extrinsic processes like fractures in the vertebral body or metastatic disease in the spine may produce compressive and mechanical damage of the spinal cord. Infections are very important when we have patients with acute myelopathy. One thing that we need to clarify if there is any evidence of infection. There are some sort of infections right now that are of particular interest. This morning, there was a very good clarification about what is going on now with acute flaccid paralysis, for example. So infection is a frequent factor that may affect the spinal cord. Vascular problems like strokes happen in the spinal cord, and we are emphasizing to our colleagues and people in the healthcare community that strokes happen in the spinal cord and occasionally are confused with myelitis. So this is an important aspect of our practice right now. So again, when we are dealing with spinal cord problems, we need to go and exercise and clarify what is the main cause of that spinal cord. So I produced this group of equations just to make fun of people that work in mathematics, but Actually, so when we think about everything related with spinal cord disorders, we need to put in an equation what are the factors associated with any disease of the spinal cord. Follow me on that? So if we are talking about ADEM, so one of the most important factors in the equation is the presence of infections or previous infections that may be viral or bacterial. When we are talking about NMO, one extremely important element of that equation is autoimmunity or immunity produced by presence of antibodies against aquaporin 4. When we are talking about myelitis, is inflammation of the spinal cord that may come from viral infection, may come from autoimmunity, may come from different factors. But anyway, the common denominator of that is the specificity of the organ involvement. In the case of ADEM or multiple sclerosis, occasionally the spinal cord is the main target, but brain is also a target. In the case of NMO, the spinal cord is a target, the optic nerve is a target, the brain is a target. In the case of myelitis, the prime target is the spinal cord. So in the past 15 years, we have learned about many immunological disorders that target the spinal cord. When we start with the Transverse Myelitis Center at Johns Hopkins, the classification of all of these disorders were a mix of problems associated with multiple sclerosis, neuromyelitis optica, rheumatological disorder. But in the past several years, we have been learning more and more about many of those disorders. And with the introduction of and the better understanding of immunology, for example, we were able to take neuromyelitis optica patients out of the spectrum of multiple sclerosis. As you can, many of you may remember, back in the 2000s, even before, many patients with neuromyelitis optica were diagnosed in the spectrum of MS. So in the past many years, we learned more about the immunology of those disorders. So the diagnosis of neuromyelitis optica is quite specific and is out of the sphere of MS. And even the diagnosis of transverse myelitis that was in the sphere of multiple sclerosis back in the 90s and early 2000s is completely out of the sphere of multiple sclerosis. So we had a better understanding, and right now what we are doing in 2015 is we have a more complex classification of many of the disorders that happen in the spinal cord. We have, for example, a better understanding of vascular myelopathies. We have now a much better understanding of the NMO spectrum disorders and all of those disorders associated with immune features. So in other words, every year we are learning more and more and more, and I think that we are focusing in identifying etiological aspects of transverse myelitis. In the past several years, what we have done, for example, is to clarify if patients with transverse myelitis were really myelitis or inflammation of the spinal cord. What we have learned in the, is that there is a subset of patients with transverse myelitis that really don't have transverse myelitis in the strict sense of the word. So transverse myelitis is basically an inflammatory myelopathy, and many conditions may produce inflammatory myelopathy. Inflammatory myelopathies are frequently associated with immunological damage, inflammation of the spinal cord that may be triggered by several disorders like neuromyelitis optica, multiple sclerosis, sarcoidosis. So when we go and analyze a patient with a spinal cord disease that we are suspicious about inflammation, we need to go and try to identify if that inflammation is the result of MS, NMO, an infection, a post-viral infection, or is associated with some sort of infectious disease like enterovirus, D68, etc. So the responsibility of the healthcare team when there is a diagnosis of inflammatory myelopathies, make sure that we identify etiological factors. So what we have seen is that many patients are diagnosed with transverse myelitis, and actually they don't have the real transverse myelitis. They have other causes of myelopathy that may include strokes, and that is one of the aspects that we have been doing in the past several years, is try to understand what is the main characteristic of the the diagnosis of myelopathy. So we are using MRIs. MRIs are very helpful. However, I will caution to you is the human brain of a clinician is still very important for diagnosis of medical problems. So don't believe that the MRI is the only thing that is helpful to diagnose spinal cord disorders. We still need the human brain and the clinical analysis to reach a diagnosis. So that's the reason I say computers are going to help in the near future a lot, but they are not going to replace us for making a clinical diagnosis and decisions about management. So what I want to tell you is the MRI is helpful. We have used, for example, MRI and presence of enhancement of the spinal cord in the MRI to diagnose myelopathies. But the fact is that the presence of enhancement in spinal cord disease that we believe that is associated with inflammation is not necessarily a very specific approach to say that there is inflammation. Why? Because there are many other disorders. So in the case of inflammation of the spinal cord in myelitis, we can see in the blue bar the number or percentage of cases that were enhanced, that the MRI show enhancement. But guess what? There are other disorders like vascular problems that produce abnormalities in the spinal cord, or even problems of spondylosis, that is the spine discal degeneration of the spinal cord. Those patients also have some degree of enhancement in the spinal cord. So a spinal cord MRI with gadolinium enhancement is a good way to evaluate problems, but it's not a specific way to establish a diagnosis of myelitis. So vascular problems are very challenging to us right now. We believe that vascular problems are important to be evaluated, and the fact that in our patient population, almost a third of our patients were with transmyelitis were misdiagnosed, and they really had vascular pathologies is extremely important. But if you pay attention to this list of causes of myelitis, there are other things that are neither inflammation, neither vascular problems, and are a mix of other causes that may include vitamin deficiencies, genetic disorders, metabolic disorders. So it's extremely important that clinicians be aware about that. So we have paid attention to vascular problems in the past several years in our institutions. Spinal cord problems associated with vascular abnormalities are relatively frequent. We are paying attention, for example, to the presence of disorders of vascular supply associated with abnormalities of veins and arteries in the spinal cord that are called arteriovenous malformation or dural fistulas. Those vascular abnormalities frequently produce extensive damage of the spinal cord, and you can see in this MRI presence of a longitudinal extensive myelopathy in which there was some degree of enhancement, and this patient basically had a dural fistula of the spinal cord that was the main cause of this spinal cord abnormality. And again, some of these patients, unfortunately, are not very well diagnosed at the beginning, and they experience a lot of limitation until the vascular abnormality is diagnosed. And in the majority of patients, there is opportunity to fix the vascular problem if we find evidence of arteriovenous malformation or dural fistulas. But in other patients, unfortunately, that solution is not available. So these patients with vascular problems are not patients that need to receive IV immunosuppression or need to receive a plasma exchange or IVIG. Those are patients that basically need other type of abnormality of treatment to control the abnormalities. And I need to pay attention also to the fact that occasionally what I call extrinsic mechanical effects on the spinal cord, like a process of discal herniation or compression of the spinal cord, may induce changes in the spinal cord that mimic myelitis, and clinicians need to be very, very cautious about that. This is a patient that actually is a young patient in early 40s who was diagnosed with transmyelitis, underwent treatment with plasma exchange IVIG, and actually the problem that the patient had was basically a mechanical effect on the spinal cord. And you can see that the areas in which there was discal herniation, there was focal inflammation of the spinal cord that initially was misinterpreted to be associated with myelitis. So vascular abnormalities are important, so we need to pay attention to vascular abnormalities in the spinal cord because the vascular supply of the spinal cord is quite complex. Each level of the spinal cord get a supply of arteries, and when there is any pathology in any of those small blood vessels, the spinal cord is obviously going to be dysfunctional. So the vascular supply is very critical because vascular supply in the upper portion of the spinal cord may lead to infarction and dysfunction that may mimic myelitis, like in this particular patient in which the spinal cord was affected, and this patient actually had evidence of some abnormality in the anterior supply of the anterior blood vessel supply, and this patient developed this symptomatology that mimicked the symptoms of of myelitis, but the cause of the problem was completely different. And this is similar to what I showed you before. These are vascular problems on the spinal cord in the portion of the lumbar or thoracic spinal cord and are associated with other type of pathologies in the blood vessels. So when we deal with myelitis and myelopathies, the other thing that we need to understand is what is the pattern of involvement that we may have in that clinical profile. And we are paying particular attention to the temporal profile of a symptom. If the problem is presented acutely or hyperacutely in a matter of hours, most of those patients may have pathologies associated with vascular supply. Patients with MS, NMO, or inflammatory myelopathies frequently develop symptoms over hours and days, and those are patients that we call patients with acute symptoms associated with the myelopathy. And when patients keep having relapses and remission of symptoms, those are the patients that we call relapse and remitting symptoms. And those are patients that may experience problems like multiple sclerosis or neuromyelitis optica. And patients occasionally may have a very chronic evolution of the symptoms, like happened in those patients in the blue line, and those patients are frequently associated with other type of pathologies, particularly venous abnormalities of the blood of the spinal cord or inflammatory disorders as well. So I think that in the equation of analysis, we need to come with different diagnosis, and we need to make sure that we diagnose the patient correctly. So I believe that my time is okay. Very good. So I will stop here, and I hope that at the end of the sessions I will be able to talk with some of you and clarify some of the questions that you may have. Thank you so much.